In chronic kidney disease, it's a different story. Obviously, there's a really important reason for screening for chronic kidney disease in our patients with diabetes, because we're not going to know it until it's too late because it's asymptomatic. We know that our patients are at risk because they have diabetes, and now we have very clear evidence that early intervention makes an enormous difference to outcomes in this setting. But the real question, and the real reason we're having this symposium today, is the question is, can individuals with or at risk of CKD be easily identified at this early treatable stage? Currently, we have a kind of a fire risk for kidney disease, but it talks about the risk of developing kidney failure, such that those people in the green zone with normal amounts of albumin and normal EGFR seem relatively good right up until the point that they drop below an EGFR of 60, where they go into a range of impaired kidney function. And this is likening, if you like, you've got a dozen eggs with an EGFR of 120 for numbers of equality. So if you only care about preserving eggs, but you only treat after you've lost half a dozen already, that's what treating with an EGFR of 60 is like. It's after, not after the horse is bolted, not after the MI, but after you've lost 6 of 12 of your eggs. Equally, by the time you refer to a nephrologist, you've only got an EGFR of 30, you've got 3 of 12 left, and what are you supposed to do then? So the real utility is doing things earlier. And with that, I'm going to hand it over to our first speaker at this symposium, Professor Karen Yandelai Dam, whom you'll hear a little bit more about at this symposium, who's going to talk about what it's really like to have diabetes and CKD and why it's so much important to prevent it. Thank you, Karen.
Thank you, Merlin, for this nice introduction. And I'm a practicing nephrologist, and I provide a renal service in the Baker Heart and Diabetes Institute and at the Alfred Hospital. So I see people with chronic kidney disease and diabetes every day, and they usually refer to me when, as Merlin just pointed out, when their EGFR is 30 or lower, when it's usually too late to do massive changes. So what is it really like to have chronic kidney disease? People with type 2 diabetes have a very high lifetime risk of chronic kidney disease. And these are data here from the UK PDS study, where we see over time, we see a doubling of serum creatinine, we see macroalbuminuria development, microalbuminuria development, and reduced EGFR or creatinine clearance. And you can see that CKD was found in 3 in every 4 people over a lifetime. So it's a very common event. And this is a study performed by the chair, Professor Merlin Thomas, in the NEPHRON study, showing in type 2 diabetes individuals there was already kidney disease present, if you look at in a sort of a cross-sectional study, with over 24% or 26% having microalbuminuria, a smaller proportion having macroalbuminuria, and a smaller proportion having a reduced reduction in EGFR. But if you group this together according to the KDIGO guidelines, we see more than 50% had already pre-existing kidney disease by the time they have diagnosed with type 2 diabetes. And it is a clustering of the comorbidities that's also really contributing to the overall disease burden of the individual patient, but also of the global society. We have cardiovascular disease, extremely high risk, up to 10 times folder if you have chronic kidney disease, hypertension, which also contributes to the progressive fall in renal function, and heart problems, including cardiovascular disease, heart failure, but also rhythm problems. So what is the burden really? The presence of chronic kidney disease is associated with poorer outcomes. We have increased hospitalizations, also increased incidence of acute kidney failure on top of the chronic kidney failure. We have adverse drug reactions, heart attacks, peripheral vascular disease and stroke, an increased number of heart failure, but also rhythm problems, as I just pointed out previously, with sudden death occurring, The all-cause mortality is significantly increased. And of course, the quality of life, and when we looked at the disability-adjusted life years, that's significantly impacted by the disease. And then a large proportion of these people will progress to end-stage kidney disease. And this is another whole area we can talk about how this impacts life, which is really significant. Going to dialysis 3 times a week for 4, 5, or sometimes 6 hours. If you calculate the numbers, as Professor Richard Meisig has done in his report, it comes up to an enormous amount of numbers per year you spend on this dialysis machine. And then we have transplantation, which is also not easy, and some people even cannot get a transplant. So this is what chronic kidney disease really looks like. It's really associated with a significant mortality, and patients over 65 with chronic kidney disease are 6 times more likely to die of cardiovascular disease, and they don't even make it to the stage where you can start renal replacement therapy. So it is a very significant burden. So these are data here from the Hong Kong Diabetes Biobank, where you can see if you have, according to the KDIGO guidelines, a reduced EGFR and an increased albumin-creatinine ratio, you do the worst. Your all-cause mortality in blue here, in the blue line, is significantly higher. The incident kidney failure is much higher. And if we look at cardiovascular disease, it's the worst outcome, and hospitalization for heart failure. So there is, even with the increasing rise of diabetes, with the epidemic of diabetes, we also have an increasing death rate. And currently it ranks among the top 10 causes for death, but it is predicted to go even higher than like the 5th place in the 10 leading causes of death over in 2040. And in some countries, as you can see here, in Central America, it's even at the moment the 2nd ranked cause of death. So if we are not doing something about it, this might be where we end up in the long term. And there is a large unspoken burden of kidney disease. It's the patient cost in terms of visits to the GPs, the specialist centers, the dialysis costs, ability to work. Some people have to give up their work. I had a construction worker had to give up his work. Ability to travel. I hear this many times. Next year I'm going to do on this cruise I have saved for the last 5 years. Well, with a kidney function of 10 or 15, probably not going to happen anymore unless you have a lot of money and pay for dialysis overseas. Quality of life is significantly impacted, day-to-day life, but also, just the normal things in life are sometimes impacted. Dietary issues, fluid balance, all these things can really put a heavy burden on people. Energy, tiredness, sometimes associated also with renal anemia, which we can treat, but still reduced energy levels are very common. And of course the psychosocial stress, and as pointed out in your report, there's also a high burden of depression, not only for the patients but also for the caregivers. And I added fluid and diet restrictions are sometimes a heavy burden. So what does this really mean in chronic kidney disease for your patient? They really need help. And maybe the solution is really to detect people earlier who will progress, and then we can still do something about it. And that's, I think, what we're hearing in the next presentation. Thank you.
My pleasure now to introduce Professor Richard Meisig. Now that you've heard already what the danger is, the bushfire, how do we detect the risk early in order to give ourselves a fighting chance to prevent that? Richard.
Thank you very much, Mel, and thanks everyone for turning up today to this session. So I'm going to be talking about standards of care, screening and diagnosing CKD and type 2 diabetes, and really what I want to do over the next 5 or so minutes is just to point out some of the problems that are associated with measuring albuminuria, if you do measure albuminuria, and that is something we'll be talking about, and the other established marker of kidney function, GFR, which of course we only estimate at the moment. So, to start with, let's see what the guidelines have got to say about screening for CKD. So these are the KDOKI guidelines published 2 years ago. CKD screening should be implemented in individuals with established CKD risk factors, hypertension, diabetes and or cardiovascular disease. I'm an endocrinologist, so I'm going to be focusing on diabetes, but we will expand my presentation to talk about CKD a little bit more in general. So when I think of guidelines, I always like to go and see what the American Diabetes Association standards of care have got to say about a certain topic. And thankfully, in the last year or so, CKD has actually got its own guideline. It's not thrown in with the other microvascular guidelines. So what do the ADA say about screening for CKD and diabetes? So let's talk about albuminuria. At least annually, we should ask our patients to collect a spot urine sample to check on the albumin to creatinine ratio. And once a year, we should also get them to have a blood sample so we can estimate what their glomerular filtration rate should be. And we should start doing this after about 5 years of diagnosis of type 1 diabetes. I think it's quite flexible. If someone's got very poorly controlled diabetes, maybe other risk factors, I might start screening a little bit earlier on. But we screen at the time of diagnosis for people with type 2 diabetes because we're not quite sure exactly when they crossed over the line to make the diagnosis of type 2 diabetes. And as we know, many people, when they're diagnosed with type 2 diabetes, have some of the manifestations or complications of diabetes already. So let's just talk about EGFR to start with. So what should we do in terms of testing for EGFR? Well, as I said, at least annually, maybe depending on the circumstances, we might be checking on EGFR a little bit more frequently, and importantly, maybe looking at a gradient of change in EGFR. So if you find that EGFR is lower than what you think, and maybe an unexpected, if you've got maybe a previous EGFR, I think one thing to keep in mind is this an acute or a chronic situation? Because acute kidney injury could drop your EGFR down. So I think just to be careful that you recheck their EGFR. Remember, we're talking about chronic kidney disease, so we want to make sure that it's a chronic situation where their EGFR is low. And remember on the heat map that Merlin showed, if your EGFR is below 60, even without the presence of diabetes, and it's a chronic situation with reduced EGFR, that can put you into a diagnosis of chronic kidney disease. So let's summarise what we know about EGFR as a biomarker of chronic kidney disease. Well, generally it has a low variability, although diet and hydration status can make a difference to that. It's usually highly specific for kidney function. After all, the glomerular filtration rate tells us what the kidney is actually doing. Once it drops down in a chronic fashion, it's unusual for it to regress to go back up again, but we've already talked about situations where you might see the EGFR rising, say if it was a situation of acute kidney injury. And I think one thing to keep in the back of our minds is that currently, when we talk about GFR, we're only estimating GFR from serum creatinine. There are other factors that go in there, maybe to account for what the serum creatinine might be independent of kidney function, for example, age and gender. But remember, it's only an estimate. And as Merlin has already pointed out, when the GFR starts dropping down below 60, a lot of damage has already happened to the kidney. So it's a late biomarker, shows loss only after it has occurred. And the other thing that we're becoming aware of, especially in the situation of diabetes, is that estimated GFR based on serum creatinine formulas, CKD epi formula, are not really that good at estimating what true GFR is in the normal to high range. There's a number of studies showing that while modifications to the formula might have improved the estimation in people without diabetes, there seems to be something particular about people with diabetes where the EGFR formula doesn't perform all that well in the high normal GFR setting, which is a real problem for a diabetologist and endocrinologist, because we're trying to estimate and slow down the decline in GFR before we send our patients to see people like Merlin and Karen. So let's move on. I might just skip over this slide because I think I've already talked about the problems in terms of EGFR being a good measure of true GFR in the high normal range. Let's just move on now to talk about the other commonly used marker of chronic kidney disease, urinary albumin excretion. So Merlin's kept things here in the American units, but remember, we're in Australia, SI units, millimole per milligram, so just divide by 10. It's easy. So we already know that, and we'll talk about this in a moment or so to highlight this fact a little bit more, that urinary albumin is the level of urinary albumin can be quite variable. There are other factors that can put urinary albumin up apart from kidney dysfunction. And just in the normal individual, there's a high rate of variability. So we need to have more than one measure before we know where we are. So just like for GFR, I've tried to summarise some of the issues surrounding the use of albuminuria as a biomarker of chronic kidney disease. I've already talked about its high variability, has a low specificity. Lots of other things can put up urinary albumin, and I've listed those here. So if you've got a fever, infected tooth, for example, that'll probably put up your urinary albumin excretion rate. The other thing that we've come to learn about urinary albumin is that it's quite commonly a marker that might even regress back to the normal range without any specific intervention. In the early 1980s and the 1990s, I think if you looked at any or read any review on diabetic kidney disease, you'd probably pick up on this undercurrent of thinking that once you developed albuminuria, you're on a set course, like the train travelling down a track. Urinary albumin level would keep increasing. You'd go through the microalbuminuric range, macroalbuminuric range, and then your EGFR would start dropping down. But over time, we've learned that people can spontaneously regress their albuminuria, and I'll show you a slide on that in a minute. And the other thing that I think we really need to keep in mind is that changes in albumin excretion, or ACR, don't always reflect changes in GFR. So we just have to be careful. Albuminuria, marker of kidney stress, GFR, kidney function. So what about measuring albuminuria? Well, really, in Australia, probably no excuse for getting a patient and giving a PAF slip to a patient and getting them to do a spot urine collection and getting it measured properly. Proteinuria, sometimes is something we measure. If I'm sending someone to see Karen or Merlin, I write spot urine, ACR/PCR, just to help the nephrologists to think about albuminuria at times, because I think they're used to thinking about proteinuria. So urinary albumin excretion, when measured as the urinary albumin to creatinine ratio, so it specifically detects albuminuria, which is an early and stronger association with clinical outcomes. It doesn't measure non-albumin proteins and is required to appropriately stage CKD. So I've already said, try and check albumin to creatinine ratio rather than PCR, which you might be able to do later on as a patient's GFR drops down. It has a greater sensitivity for picking up kidney dysfunction or the kidney being under stress than proteinuria. Ideally measured as a single spot urine collection. First thing in the morning is probably the best time to do it. You might see the fact that in some clinical settings that a dipstick has been used. The dipstick to measure proteinuria, which might often used on the wards, insensitive to pick up those low levels of albuminuria. There are some specific albumin dipsticks which I think could be used in the setting of maybe limited resources, but in Australia I think there's probably no excuse for getting our patients to have a spot urine collection to measure their albumin to creatinine ratio. So this is a schema outlining how we should screen for chronic kidney disease, even outside the sphere of a person with diabetes. So think about those high-risk people that I talked about in my first slide: diabetes, hypertension, established cardiovascular disease, smoking, Aboriginal and Torres Strait Islander people, who of course got very high rates of chronic kidney disease. So at least annually, measure their EGFR and get them to collect a spot urine sample to measure their urinary ACR. If you find one urinary ACR elevated, I usually just say to a patient, might depend a bit on the level, this is just a sign, possible sign your kidneys are under some stress. We need to repeat this again before we know exactly what's happening with your albumin excretion rate. For EGFR, well, it's below 60. It's good to know if you've got another measure there in the past, try and rule out whether this is the result of an acute kidney injury, and then you can work your way through the algorithm down there. So just to remember, you can have chronic kidney disease with an EGFR below 30 without albuminuria, proteinuria, and I've spent a bit of time looking at this issue of progression of chronic kidney disease in the absence of albuminuria. I've worked on a few things with Merlin in this area. So a large percentage of our patients with type 2 diabetes will progress to have a low EGFR even without a significant rise in albuminuria. So we've tried to summarise some of these concepts regarding the screening of chronic kidney disease in people with diabetes in this report that was mainly written, did a lot of the drafting. Rodney's a PhD student at the Austin under Professor Alif Achinki, who really led this project, and I think I was a little bit of a helping hand in the end. So should I maybe stop there, Merlin, or keep going? I don't want to take up too much time, but I might just finish with this, with these quotations. You might have something to say about someone who wants to quote themselves, but we wrote this review a few years ago, highlighting the limitations of albuminuria as a screening test for CKD in people with diabetes, and also as a marker of progressive kidney disease. And at the end of this review, we said conclusions regarding the kidney health of individuals with diabetes will continue to be flawed if inappropriate emphasis is placed on the presence or absence of albuminuria or changes of albuminuria within the microalbuminuric range. And I think our last take-home message from this review was there's a need to develop broader models of progressive CKD that include novel pathways and risk markers apart from those related to the traditional albuminuric pathway to renal impairment. So that's probably a good introduction to our next speaker, and I'll get Merlin up to perform that role. Thank you, everyone.
Thank you very much, Richard. So you can see from the first speaker, Karen, that we've got something that's really important and something that's really worth preventing. And now you've been able to see from Richard that although we can detect it when it's really bad, we really don't have the tools that we really want to be able to see those patients who are slipping early down towards kidney disease before they've lost their eggs, glomeruli. But how can we change that? So it's my great pleasure to introduce our next speaker, Dr. Kirsten Peters, who is Head of Clinical Studies and Senior Biostatistician with Proteomics International. Kirsten.
Thank you so much, Merlin, and thank you everyone for coming. It looks like we've got a jam-packed room full, and in fact I think we could have done with a bigger room. So thank you for joining us. So what I want to tell you about today is some of the work we've been doing at Proteomics International on CKD and diabetes. And as we've heard from the previous talks, CKD is asymptomatic. There's no signs, there's no symptoms until the disease has progressed. And at this stage, there's significant irreversible loss of nephron mass. Many patients are non-albuminuric, and some of these patients can regress spontaneously. People can lose kidney function via EGFR but have normal albuminuria and vice versa. So what if we could do a blood test to accurately determine this CKD risk? I'm one slide behind. So over the past decades, immense efforts and research have been carried out to identify and validate alternative biomarkers to existing tests. Initial findings from many studies have been promising, with a range of functionally relevant biomarkers identified, including glomerular biomarkers, tubular biomarkers, and biomarkers of oxidative stress and inflammation. And so this idea of a simple screening tool to address the unmet clinical need was something of particular interest to our team. And so we initiated a number of studies to understand and explore this. We aimed to identify novel blood-based biomarkers of CKD in people with type 2 diabetes, to assess the possible prognostic utility of these biomarkers, and whether they added any significant value to known clinical predictors, and also to explore the benefit of early treatment to slow the progression of CKD, particularly in people with preserved kidney function, that is, people that have an EGFR above 60, who are otherwise considered normal in terms of kidney function by the current standard of care tests. And so in order to do these studies, we used data from the well-known Fremantle Diabetes Study Phase 2 and the completed canagliflozin cardiovascular assessment study. FDS2 is a longitudinal observational study of community-based people with diabetes in Australia, while CANVAS is a randomised controlled trial of the SGLT2 inhibitor canagliflozin. And you can see the characteristics of each cohort on the slide. A mass spectrometry workflow, including discovery, proof of concept, and clinical validation, was used to analyse protein signatures in the blood, comparing biomarkers by different measures of kidney function. So in the discovery phase, 2 studies identified a panel of plasma protein biomarkers associated with CKD in type 2 diabetes. The biomarkers were correlated with UACR and/or EGFR, and a series of multivariate biomarker models were developed that showed that a panel of biomarkers were associated cross-sectionally with UACR, EGFR, and various CKD stages. The next step was to explore the prognostic utility of these biomarkers using multivariate modelling. And in this study, we showed that the biomarkers predict future renal outcomes over a 4-year time horizon, and that these biomarkers added significant independent benefit to known clinical risk factors, including both UACR and EGFR. The ROC curve on the left-hand side shows that there was a significant increase in performance for Model 2, which is shown in red, once the biomarkers were added to the clinical risk factors. In the graphs on the right, significant improvements in both risk classification and predicted probabilities of outcome was observed following the addition of the biomarkers to the clinical risk factors. So we had shown the prognostic utility of the biomarkers in a series of models, but we really wanted to validate this in additional cohorts. And rather than focus on a range of different models with different definitions of renal decline, a simple model, which is now known as the PromarkerD test, was developed, which contained 3 easily accessible clinical factors: the age of the patient and the HDL cholesterol and EGFR at the time of the test, combined with the best performing biomarkers across all of our models. PromarkerD scores range from 0 to 100, with higher scores indicating higher risk for renal outcomes. Scores are classified as low, moderate, or high risk, defined by test cutoffs. And these studies showed that the PromarkerD test accurately predicted outcomes in 2 independent cohorts, thereby validating the prognostic utility of this test. So following the validation of PromarkerD, we next wanted to compare the prognostic utility against the current standard of care tests, EGFR and UACR. So if we look at the ROC curve, the green line shows the PromarkerD outperformed both EGFR and UACR for predicting CKD in the next 4 years. Even the combined EGFR and UACR was not able to achieve the same performance as the PromarkerD test. Now, of particular interest, for the people sitting in the green KDIGO boxes who are otherwise low risk according to EGFR and UACR, 45 of these people actually developed outcomes during the next 4 years and would have been missed by standard of care. PromarkerD identified 84% of these people, flagging them for earlier intervention. So the PromarkerD test can identify people at risk of renal outcomes, but what happens if we monitor PromarkerD scores over time? Do they decrease and improve following treatment with the SGL2 inhibitor canagliflozin? And so this post hoc analysis showed that PromarkerD scores dropped over 3 years for people on canagliflozin compared to placebo. And the effect was greatest in those that we had said were PromarkerD high risk. So in summary, we have identified a number of blood-based biomarkers that are associated with CKD in type 2 diabetes. We have demonstrated the prognostic utility of the biomarkers for predicting EGFR decline. We have showed that the biomarkers add significant independent benefit to known clinical predictors, including both EGFR and UACR. We have developed and validated a simple screening tool called PromarkerD, which outperformed both EGFR and UACR for predicting outcomes, particularly in people with preserved renal function. And the canagliflozin improved PromarkerD scores over time, with the greatest effect in people identified as PromarkerD high risk. So that's all I wanted to tell you today, and if you have any further questions or want to talk to us about this more, we have a booth number 45. Please come by and say hi. Thank you.